All right, welcome back to class. This is week number 8, and this is our first screencast for the week. Been having a lot of great conversations with some of you. Uh, if you would like to meet, we can do something in person or we can Zoom. I'm available to do that. And the reason I bring this up is because we've been having conversations around trying to figure out your research questions. And I think again, having a little conversation here for everybody can give you an idea on how to expand or potentially narrow your question. Now you've got great questions, you've got great PICOs, but now the challenge is, can I find research around that topic? And so I'm going to share an example here, and hopefully you're able to get from this example how, by making some adjustments here or there, you would be able to conduct your systematic review or scoping review. So one area that I like to do research in is with blood flow restriction training. And you see on the individual there a cuff, an occlusion cuff is applied to the proximal portion of the upper extremity. They can also be applied to the proximal portion of the lower extremity. So what occurs now is there is a decrease in arterial flow into the extremity because of the occlusion created by the cuff and the pressure applied. And there is full occlusion of venous return. So anything distal to the cuff application experiences a training effect. So right now, this individual is doing a shoulder-based exercise, and specifically external rotation. Well, if you remember your anatomy, your shoulder external rotators are proximal to the cuff application here. And so does the cuff application do anything beneficial? So can blood flow restriction training improve rotator cuff strength? So my population is 18 to 50-year-old active, healthy adults. Intervention, shoulder exercises with blood flow restriction. The control would be the shoulder exercises without blood flow restriction, and then looking at different measures of strength. Well, I know that there is limited research in this area. I've done a couple papers. Lambert's group has done some papers. Bowman's has done some, and there's been some case reports. What are the findings? So far, external rotation strength has not been improved with blood flow restriction training. But let's say I didn't even know that. Let's say I did a search and I found only a handful of studies. Well, we're going for a minimum of 8. So I've done my search. I've only found 4 studies for the rotator cuff. But what is it that I'm really trying to determine? Again, what is my story? Can BFR have proximal effects? Specifically, I'd like to know if it can have proximal effects for the rotator cuff, but I do want to know if it can have proximal effects. So maybe what I need to do is expand my search to focus on studies that investigate proximal effects. So instead of only focusing on the rotator cuff, I could instead get to 8 studies or more by including anything that was proximal that's related to BFR. For example, papers by Matarame and May, they found increases in biceps strength and size after people had lower extremity occlusion. So they did some exercises with the BFR on their legs. They also did the biceps without BFR. The biceps got bigger and stronger compared to the control group that didn't do BFR. That would be a proximal or systemic experience. Bowman et al. Did lower extremity occlusion, did exercises designed to strengthen the quadricep. Hips also experienced a benefit. Cook and Yasuda did bench press related studies. So they had the occlusion on both upper extremities, and they had people do bench press. So I could, instead of focusing on doing a systematic review or a scoping review for the rotator cuff, I could instead focus on just proximal effects. Now, I would want to look into the literature to see if this has been done already. And then I find this. And then all of a sudden I feel deflated. I know some of you have felt that way too. You feel like you find something that's already been done. So here's the effects of upper body blood flow restriction training on muscles located proximal to the applied occlusive pressure. Don't give up. Look at the article. So I quickly scanned the article. I did not see any of my studies included. That was surprising because my studies came out prior to the publication of this one. I didn't see the Madarame and May studies. Now, their focus here is on upper body blood flow restriction, but mine had that. So why wasn't mine included? Take a look at the eligibility criteria. Well, my population was healthy individuals. My interventions were the same. My comparisons were the same, right? Outcomes, looking at muscle size or strength, check. And it was a randomized controlled trial. So somehow my study and maybe other ones were missed. And so, sorry about the interruption there. I paused the recording. So I think where I left off was because of either deficits in their inclusion of papers or their focus was on applications just applied to the upper body, you could, or I could, do a systematic review or a scoping review looking at proximal strength gains regardless of where it's applied. So does that make sense, that kind of exploration of things there, where if you're having trouble finding stuff, how can you expand it? Again, a systematic review is going to basically focus on preferably randomized controlled trials. This particular systematic review, they included quasi-experimental study designs. A scoping review allows you to explore everything on the topic. I was just reviewing a student's paper from last term. We got it uploaded and submitted today, and they did it on lavender supplementation, and it was in a sense a scoping review because it was looking at not answering one question, but exploring the role of lavender supplementation for the top 3 mental health diagnoses seen by primary care providers. And so it was scoping along those lines. And so you can have a variety of different study designs. So I look forward to having conversations with you to help you expand your question if you need to expand the things that you look for. But hopefully that example there kind of gave you an idea on if you run into a dead end, how can you keep doing the same topic by manipulating a little bit what your exact research question is. Okay, so let's talk about quasi-experimental designs. Quasi-experimental designs fall in the experimental area, obviously. They are similar in their appearance to a randomized controlled trial, but they lack random assignment or comparison groups or both. Now, I first introduced you to a quasi-experimental design with the Dirks et al. Paper, that frozen shoulder paper from a few weeks back. That was quasi-experimental. Now, it looked like a randomized controlled trial because it had a control or a comparison group, and then researchers also controlled independent variables. So people were in a self-stretch group, the benign group, or the intensive manual therapy-based group. But what made this quasi-experimental was that there was no random assignment. So they had the first 30 or so individuals went into one group, and then the next 30 plus individuals went into the second group. So quasi-designs, let's explore some quasi-designs here. The first one is the one group pre-test, post-test design. So basically lacking randomization, lacking a comparison group, but you're getting an opportunity to see if there is a change in response to an intervention. Quasi-design that involves one set of repeated measurements taken before and after treatment on one group of subjects. The effect of treatment is determined by measuring the difference between pre-test and post-test scores. Another frozen shoulder related paper, Griggs et al. Utilized a one group pre-test, post-test design where they had people perform 4 direction shoulder stretching exercises. All subjects received the exercise protocol. They studied the effects on pain, range of motion, function, and quality of life measures. People were followed up at a certain point in time. Here was their routine, but there were limitations to it. There were definitely limitations to it, and they had no comparison group to know if what they were doing was more effective than just time itself. There was no control in this particular study over the number of therapy visits. That's not a component of quasi-experimental design per se, but it was a weakness of the study. The weakness of the study, there's also other visits, other treatments involved, and so again, you're not able to appreciate if the intervention that you did was the only thing that led to improvements. But strengths of this particular study is that, and this is a particular strength of all pre-test, post-test, one group designs, is that it shows the potential for treatment and that it should inspire future research. Now, there is rationale for utilizing a pre-test, post-test design. So in cases where previous research has documented the behavior of a control group in similar circumstances. For example, other studies have shown that shoulder pain does not improve in this population over a 4-week period without intervention. On that basis, one could justify using a single experimental group to investigate just how much change can be expected with treatment. This may allow one to defend the lack of a control group on ethical grounds. Looking at a one-way repeated measures design over time, many research questions that deal with the effects of treatment on physiological or psychological variables are concerned with how those effects are manifested over time. This design, which is an extension of the pre-test, post-test design, is suited to observe these trends. Multiple measurements of the dependent variable are taken within the prescribed time intervals. The intervention may be applied once or it may be repeated in between measurements. So these are examples here of what a one-way repeated measures design with time as a repeated measure, what that would look like. So an example here, this type of study design is appropriate when the time course of the disease is predictable. So for example, looking at strength declines in a linear fashion in patients with ALS. Studies for this population that look at a drug intervention may reasonably follow patients over time without needing a control group or placebo group. So again, you know that there is strength losses with that population. And so why have a control group? Because you already know that they're going to decline in a linear fashion. So you would just have the intervention group. Another example, researchers studied the effects of low-impact aerobic exercise on fatigue, aerobic fitness, and disease activity in adults with rheumatoid arthritis. Measures were obtained pre-intervention, mid-treatment, at the end of treatment, and at a 15-week follow-up period. So again, this would be an example of that repeated measures design. Time series. This design is based on the application of multiple measurements before and after treatment to document patterns or trends in behavior. These designs are often used to study community interventions and policy changes. So here is a time series design example. The example is an interrupted time series design. The researchers evaluated an intervention to reduce inappropriate use of key antibiotics by hospital staff. They initiated a policy for appropriate use of specific drugs through concurrent feedback by clinical pharmacists for individual patients. Drug use and costs were assessed monthly for 2 years before and after the policy was implemented. Now, with this study design, it is interrupted. There is a series of measurements over time that are interrupted by one or more treatment occasions. It's considered quasi-experimental because only one group is studied. The independent variable is time. Each measurement interval represents one level of time. Probably a rare thing that you're going to find. There's non-equivalent pre-test, post-test control group designs. This design is similar to the pre-test, post-test experimental design, except the subjects are not assigned to groups randomly. This design can be structured with one treatment group and one control group, or with multiple treatment and control groups. So this can be created by having intact groups. You could imagine, and I won't read through all this here, but let's say you've got 2 different groups, and because of where they were assembled, the first example here is 30 patients with neck pain. Those are the individuals who completed rehabilitation. The other 27 had neck pain, but did not receive treatment for various reasons. So they came from the population, but they weren't randomized. So they were intact. They were taken as is. So again, intact groups by virtue of their diagnosis. Here's another intact groups example. This one here, let me go back to it. This one here, what they did is people with Achilles tendinosis. They had people that were awaiting surgery, and those individuals were the ones that received the Achilles training. And then there was another group that went ahead and did surgery, if I remember correctly. They did not want to do anything. They just wanted to go to surgery. And so they were able to compare the 2 groups later and to evaluate outcomes, comparing the eccentric exercise group versus the surgical group. So again, another intact, not everybody had an equal chance of being randomized to one of the 2 groups. You can have non-equivalent pre-test, post-test control group designs based upon subject preferences. So people self-select their group membership. Although the non-equivalent pre-test, post-test control group design is limited by the lack of randomization, it still has strengths. Since it includes a pre-test and control group, there is some control over history, testing, and instrumentation effects. Pre-test scores can be used to test the assumption of initial equivalence on the dependent variable based on average scores and measures of variability. Of course, there are threats to validity. Do those people who self-select to go to an exercise group are those individuals who are already physically active, and that is part of who they are? So it's important to consider the validity issues with any of these quasi-experimental designs that lack either randomization and or control group. You can do historical controls where you take a group that is currently in the present and then compare results with a different group from the past. So you would do historical controls when ethical concerns may preclude a true control group. Now, there are disadvantages for historical controls. There have been instances where significant findings were found in a historical control study, yet a randomized control trial was unable to replicate the findings. The most obvious problem is the potential for confounding because of imbalances in characteristics of the experimental and historical control groups. For this to work, a researcher has to be diligent in establishing a logical basis for group comparisons. Those in the historical control group should not simply be any patient. The demographics should be similar. Non-equivalent post-test only control group design, also known as a static group comparison. So this is kind of an odd one, just a post-test only. This design uses existing groups who've had and not had received treatment. So here's an example of a post-test only. Researchers were interested in studying the effects of a cardiac rehab program on self-esteem and mobility in 152 patients who received cardiac surgery. They studied 37 subjects who participated in a 2-month exercise program and another 115 who chose not to attend. Measurements were taken at the end of the 2-month study period. Outcomes were based on 2 different scores. So to draw conclusions from this comparison, one would have to determine if variables other than the exercise program could be responsible for outcomes. Confounding factors should be identified and analyzed in relation to the independent variable. For example, in the cardiac rehab example, researchers considered the subject's age, years of education, and occupational skill. Although the static group comparison affords some measure of control in that there is a control group, internal validity is severely threatened by selection biases and attrition. Design is inherently weak and should only be used in an exploratory capacity, where it may serve to generate hypotheses for future testing. All right, so that is a quick overview of some quasi-experimental designs. You may come across some of these depending upon what your research question is. And probably the most common ones you're going to find are those that look like a randomized controlled trial but lack randomization, or utilize a one-group pre-test, post-test design.